Anthony Gonzalez with Miami Community Health. We're here with another important health topic for you today. You must have somebody in your family that is a cancer survivor, and thank God you do. Cancer is obviously something that affects all of us, all of our families, and something that we fight each and every day. And being a cancer survivor is a good thing. But did you know that cancer survivors have problems that they have to deal with long term because they have survived cancer? Because of the treatments of cancer, there are other issues that these patients can have. And this is new to me. I came across this idea and this specialty and this discipline of people, physicians, and healthcare providers that help these cancer survivors. So today I brought with me a colleague from Miami Cancer Institute at Baptist Health, Dr. Adrian Cristian, to talk to us today about cancer rehabilitation. So Adrian is a cancer doc that does rehabilitation. It's an oncologic physician that helps rehab physicians. So welcome, Adrian.
Great to be here. Thank you for having me.
So tell us a little bit about what you do.
So what I do, my specialty is called rehabilitation medicine, cancer rehabilitation to be more specific. And what I do every day is I see people that are on the cancer journey. They've been diagnosed or in treatment or survivors that have all the effects of cancer treatment and the toxicities of those treatments. So what I do is I treat those toxicities. The goal is very simple: maximize quality of life by addressing these physical impairments from the cancer and cancer treatment.
And so obviously, how do you become that type of physician? We were talking about that before we started the show. You know, it's very common, I see cardiology residencies and fellowships and surgery and so forth, but what's the path to become a cancer rehabilitation physician?
That's a great question. There's not that many physicians that do this around the United States. You go to medical school, you go to residency in rehabilitation medicine. I was fortunate when I came of age, we didn't have fellowships in this, so I kind of learned it on my own and kind of applied what I know in rehab medicine to a cancer population. Nowadays, you can do a fellowship, but not too many fellowships in the US, but you can do a fellowship with that. And then it's a matter of just practice and working with cancer patients and oncologists, and it's been a great journey.
Wow. So give us a perspective of what the numbers are like. Obviously, there are a lot of cancer survivors. What are we talking about in numbers?
So we're talking about 18 million Americans that have been treated for cancer, cancer survivors as we call them. And that number is expected to project to about 22 million over the next 10 years or so. That's almost a quarter of the US population as a cancer survivor. It's an astounding and astonishing number of people living with the effects of cancer and cancer treatment. And the challenge is this: when you go for cancer treatment, your only thought and wish is to get through the cancer treatment and be a cancer survivor. You'll do anything at any cost to be able to be a cancer survivor. You'll accept physical impairments, physical limitations as part of that. And what happens when you finish that treatment, and even during the treatment, when you finish the treatment, now you're left with living with the effects of these treatments, and that could be for the rest of your life. And that has a tremendous impact on the quality of your life, your work, your social roles, your hobbies. And that's where cancer rehab comes in.
Wow. So obviously you've traded one illness or one problem for another problem. So what are some of the common problems? And we're going to go through detail, some cancers and really try to educate and obviously benefit the community. But what are some of the effects of cancer treatment that you commonly have to deal with?
I think the couple that are sort of pervasive across all cancer types: fatigue. So cancer-related fatigue is ubiquitous. It's just about everyone I know has that as they go through cancer treatment. And that's the kind of fatigue that is not really by just resting. It's something that they're nonstop, day and night. It could affect mental function, it could affect physical function. So fatigue is very, very common. Another one that I commonly see is what we call neuropathy, where the cancer treatments, the chemotherapies, for example, affect nerves, hands, feet, which in turn affects balance and use of the hands, which in turn can affect all aspects of life. So these are sort of very common things that I see. Another thing is this sort of loss of muscle mass, something we call sarcopenia, or loss of flesh. And that is very common in cancer patients. And that affects your ability to stand up out of a chair, walk, balance, and so forth. So that loss of muscle mass because of cancer treatments and as well as not eating well and so forth, that has a tremendous impact on quality of life.
So obviously I understand that that's not something, this treatment, and obviously these are complex problems. and they go across a lot of systems, everything from the sarcopenia to a neurological problem. You're the physician and you're the leader of that program that we have at Miami Cancer Institute, but there are other practitioners and healthcare providers that are part of the team. Can you talk a little bit about the team and how that works together in helping these patients?
Yes, that's a great point. So obviously I can't do that by myself. It requires a team. And the team really is put together based on the impairments or the physical limitation that the patient has and their goals. So physical therapists are part of that team, occupational therapists, speech therapists if someone has a speech problem related to cancer and cancer treatment. I'm very fortunate to work with psycho-oncologists and psychiatrists that specialize in cancer, in the mental issues of cancer patients, massage therapists, acupuncturists, palliative care physicians. This is all the team that we have at Miami Cancer Institute for our patients.
Wow. And so one of the things that you said, which is interesting, and I was listening to this one of the problems of fatigue. Do you think it's a mental fatigue, a physical fatigue, both?
Both.
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 And so how do you, without getting into a lot of depth, how do you treat fatigue?
That's a great question.
Besides rest, right? I mean, rest, right? And if you have rest, but but how do you treat that fatigue? Obviously the mental component, you may have some mental counseling and mental health counseling, right?
Yeah, so the fatigue itself, first you look for any treatable cause of a fatigue. Sometimes it's anemia, sometimes it's medication related, like pain medication is very common that people take. They can cause fatigue. So you look for treatable causes. Sometimes it could be what we call electrolyte imbalances that could be treated. Sometimes it's nutritional reasons, they're not eating enough, don't have enough energy. So you look for treatable things. Once you address those, then you think about like, okay, well, is it fatigue because they're not moving very much? They've lost strength, energy, muscle power, that sarcopenia, as I mentioned. And that could be treated with exercise, with resistance exercise of the key muscle groups, nutrition as well, improving the cardiorespiratory endurance, aerobic exercises, walking, simply walking, putting together a walking program to improve that aerobic fitness.
Yeah, you know what? And actually, in a non-cancer survivor as myself, I've seen that the more that I exercise, the more energy that I have and the less fatigue that I have. I'm more tired when I'm not exercising than I am when I do exercise. So actually the activity, it kind of works opposite of what you would think. You think that if you're doing more activity, you'd be more tired, but that's not the case, huh?
No, not at all. And I think in our patients, actually, that's more of a problem because so many things that are going on limits their ability to move. It makes them more tired during the day. So gently increasing that level of activity, improving their strength, their flexibility, their endurance. I think those are important key concepts that we strive to address.
All right, so now we understand that obviously there is a program at Miami Cancer Institute that's focusing on cancer survivors and all the implications of cancer treatment, the consequences of surgery, I guess the consequences of radiation and even chemotherapy, even the psychological consequences of having cancer. And so I want to go over some of the common cancers that we encounter. And I want to understand, kind of what are some of the common problems that these cancer survivors are going to have. And maybe, we have people in our community that are having these problems. And then what Miami Cancer Institute and what you and your program can do to help them. What do you think about that? That's a good idea.
I love it. And I think it's an important concept because one message that I want to share with your audience is that not to accept the normal that I got through the cancer, I'll live with what I have left, and that's it. That's not a new normal. There's things that you can do to improve the quality of life by addressing those physical impairments. And we'll talk about some of those in a moment.
Wow, that's great. That's great to hear. Okay, so let's talk about one of the common ones, breast cancer. So what happens? What are some of the cancer treatment consequences of breast cancer?
So in breast cancer, very common, what I see is shoulder problems. Because of a combination of the surgery, the radiation, systemic therapies, the shoulder is very often involved and injured and impaired in breast cancer survivors. And as a result of that, if you can't move your shoulder, just think about how many activities that you can't do in your daily life. So shoulder problems are very common. Something known as lymphedema or swelling of the arm, for example, in breast cancer patients, that can also affect the ability to use one's arm. Hand problems. Very commonly, there's certain medications that are used in cancer treatment that can have side effects that affect hand function. So joint pains, difficulty with dexterity and use of the hands, for example. Others could be the what we call peripheral neuropathy because of systemic therapies, which can affect walking, balance, or use of the hands. Something known as chemobrain or cognitive impairment, where the effects of chemotherapies or perhaps the cancer or cancer treatment that affects the brain can cause that mental fogginess that we're talking about, or difficulty with memory, focus, concentration, things of that nature. So these are the kind of things that they commonly have, and that then has an effect on the quality of life. If you add to this the idea that they can also have problems from diabetes or heart disease before they came to cancer, or maybe getting older, have age-related changes, all these kind of build one on top of each other to basically lead to this impaired quality of life.
So obviously, when somebody has a shoulder problem, then when you you have to get them to an orthopedic surgeon to help them, or how do you deal? Because I've heard a lot. What I'm hearing a lot about breast cancer is a lot of it is more of the arm, the shoulder, the hand. How do you treat some of these conditions?
So I think rehabilitation can play a very significant role in this. Physical therapy to restore that motion of the shoulder, strengthening exercises for shoulder muscles, for example, massage therapies. Very commonly, people will have what we call post-mastectomy pain, or pain around the surgical scars from the breast cancer surgeries. And that could be a source of pain and limited motion of the shoulder. So that can also be addressed with physical therapy. Medication sometimes as well can be helpful with that. But the goal is to start early, not to wait until the arm is so frozen that it can't move at all. So what we do, basically, we see these folks before they start their cancer treatment, before the surgeries, whenever possible.
Okay.
And then we see them right after the surgeries. And we start this process very quickly thereafter to minimize that loss of function on the shoulder so that they don't have weakness and impaired quality of life as a result.
Wow. So yeah, it's almost preventative in nature.
That's a key point. So the idea is we want to prevent these things from happening in the first place, and if we can't, then mitigate them once they do occur. So the goal is that they don't have significant loss of function.
All right. So I'm old enough to have seen a lot of lymphedema. Obviously, cancer treatment of the breast has changed. For our public, it's the patients that have mastectomy and they have swollen arms, and you may see somebody in your community with that. Number one, is that still common? And if it is, or what is the treatment nowadays? Because what I have seen, through the years is somebody wearing like a sock on their arm. Is there other treatments for that swelling in the arm after mastectomy?
Yeah, so that's a great question. So there are certain risk factors for developing that swelling of the arm. For example, radiation therapy that involves lymph nodes, the removal of lymph nodes as well, surgery for breast cancer as well, and systemic therapy. So these are the main risk factors. Fortunately, we have a screening program. So we do baseline evaluation of the arm before surgery. Then every 3 months in the first year or two, we follow and track and carefully see, is there an increase in the fluid of the arm? So we've been very fortunate that we identify these lymphedema very early in their cancer journey. So it doesn't get to the point that it gets too large and then it affects quality of life. There's a lot of treatments out there. Certainly the compression sleeve is the main component of that, but so is physical therapy, certain types of manual lymphatic drainage, as it's called, gentle type of massage, as well as compression pumps, strengthening exercises, educating the patient to minimize risk of infections of the arm. So very commonly they get infected, that makes the arm swell up even more. So the idea is that you teach them how to minimize that from happening. Gentle strength training, as well as weight reduction. Very common to see women after breast cancer gain weight for a variety of reasons. And weight management can also help with reducing that lymphedema risk.
Wow. All right, so let's switch gears a little bit. Let's talk about gynecological cancers. So for our public, the gynecological cancers will be the ovarian cancers, the uterine and endometrial cancers, any cancers down there in the women parts. So what type of problems do those patients suffer from?
There's a couple. First, something called pelvic floor dysfunction, where there could be incontinence of urine, sometimes bowel as well, sexual dysfunction. It's pelvic floor dysfunction because of a combination of the treatments for the cancers. There could be swelling of a leg. So lymphedema of the arm in breast cancer, you could see lymphedema of a leg or legs in gynecologic cancers. Because of the systemic therapies, such as chemotherapies, that can affect nerves, there could be problems with neuropathy, or that inability to feel when one's walking, affecting balance, for instance, or the hands because of systemic effects on the hands. These are very common, and also I find that sarcopenia, that muscle, that loss of skeletal muscle mass, especially in people who are a bit overweight or obese, we cannot really tell that. That's also a significant problem in these patients.
Okay. And obviously, again, it's getting to them early. It's getting to them early, and obviously telling our community that there's hope. I think that's one of the things that you mentioned early on, that you don't have to live that way if you're having these problems. A lot of women obviously may have pelvic floor problems, whether it be incontinence or sexual dysfunction, and they don't want to tell anybody about it, and they have to live that way. But you're saying that that doesn't have to be that way.
That's absolutely correct. So I think first and foremost, bring it to the attention of the providers. Say what's actually happening. What are you experiencing? We have a team, for instance, at the Miami Cancer Institute and throughout Baptist that can address these kind of concerns. So we have therapists that are specialized in what we call pelvic floor dysfunction to strengthen the pelvic floor muscles to help with incontinence, for example. There's also a sexual dysfunction clinic and program practitioners at Miami Cancer Institute, as well as throughout Baptist, that can address some of these concerns. With respect to the swelling of the legs, again, what you mentioned before, the earlier we get to them, the better. So if we can get them to screen them before their cancer treatment to establish what is the fluid status right now in their legs, over time we can track that, give them the compression stockings, compression pumps, manual lymphatic drainage therapies. There's a lot of things we could do, strengthening the key muscle groups of the legs, which, believe it or not, every day when we stand up, you require the power of your thigh muscles, buttock muscles, core muscles. Think about how many times a day we get up out of a chair. Mm-hmm. And in someone who has cancer or is treated for cancer or gynecologic cancer in this particular example, that strength is reduced significantly. The muscles are affected by all these treatments. So their ability to stand up out of a chair gets compromised. So if you can't get up out of a chair, how many things can you do in your daily life? So if we could focus even narrowly on these physical problems by really detailing what they are and really putting this team approach to it, then you got something.
Wow, incredible, incredible. All right, so let's switch gears and let's talk about lung cancer. Lung cancer is something obviously very important to me. My dad was diagnosed with lung cancer. Unfortunately, by the time he was diagnosed, it was stage 4, and he only survived a year. And obviously didn't have, the consequences of treatment because he was on treatment till the end. But what are some of the problems that survivors of lung cancer will deal with?
So in lung cancer, it's a very unique type of problem, especially stage 4, since you mentioned stage 4. Very often, lung cancer patients come to lung cancer sort of frail to begin with. They may have been smokers for many years. As a result, they're frailer. They may have lung COPD, lung problems to begin with. So what I find typically is that they may be frail, lost a lot of muscle mass, and they may have had surgeries for their lung cancer, which reduced their lung capacity. So as a result, they don't have as much energy to do activities in their life. The systemic therapy, such as for the chemotherapies, can cause neuropathy. Mm-hmm. And so all of these together make that person frailer. If you think of building blocks as to one thing on top of another on top of another, so then what we try to do is try to kind of work backwards to see what is the actual problem in this case. Is it the fact that they have poor nutritional status because they just don't have the energy to eat as much, so we get nutritionists involved? Is it the strength issue? Physical therapists involved? Is it the fact that they can't have enough energy or can't breathe very well for daily activities like folding laundry, for instance? There's energy conservation techniques you could include. So there's all sorts of different approaches, but the idea is you start with listening, truly listening to what the person is telling you about their physical function and what's important to them. Sometimes what's important to them might be just, I want to walk my granddaughter to school every day. The idea is, okay, let's work backwards. What do you need to accomplish that? You need to stand up out of a chair to start with. So you see how we can build on that.
Wow, that's incredible. And, I think one of the important things you say is you have to listen. And that's what happens in a lot of times in healthcare, that you're not listening to the patient. And, you guys obviously are doing a great job of not only listening, but, digesting it for them and breaking it down into pieces so that you can accomplish the goal that the patient may have. So that's incredible. Thank you for doing that. So let's switch a little bit to head and neck cancers. And for our public, head and neck cancers are the cancers up here in the head and the neck. And obviously we could see sometimes is if somebody has had cancer in their mouth or their face or their tongue, they can affect everything from breathing to swallowing to eating. So I could simply understand, but I want you to be more eloquent in your discussion and explaining to us, some of those issues. But it's easy to understand that cancers up here in this area can affect ability to speak and eat, right?
Absolutely. So head and neck cancer patients are treated with a combination of surgery, where they take out lymph nodes, for instance, and the neck area, radiation therapy, systemic therapies. So as you mentioned, swallowing can be affected by this. Speech can be affected by this. Nutrition can be affected. If you can't swallow very effectively, you lose a lot of weight, and that has certain repercussions as well. There could be a swelling or lymphedema of the neck because of removal of lymph nodes and radiation to the neck area. And that could be aesthetically a problem for the person, but also swallowing could be a problem as well. In addition, sometimes with certain types of surgeries and radiation therapies, there could be shoulder dysfunction because nerves that supply muscles to the shoulder are also affected by this. So as a result, the person may not be able to raise their arm above their head. So in addition to this, there could be the neuropathy that we talked about a little bit earlier, and fatigue as well. The challenge in this population is, how do you minimize this to begin with from happening? And then one other actual point I want to make is trismus, and that's the difficulty opening the mouth, which you can also see. So one of the challenges for us is, how do you minimize this from happening in the first place? And then once it's occurred, how do you minimize it from getting worse? Something known as the late effects of radiation therapy, where there's scarring of tissues as a result of the radiation therapy. And that could be sometimes months to years after the original treatment. The person comes in saying, I can't lift up my head, and you examine them, they have a lot of scarring from radiation to the front of their neck. So these are the challenges, and one of the important challenges that I see is also there's a very strong mental health component to this. Suicide in this population is incredibly high, depression very high. So you have to think of the individual in the totality in this case. Really thinking about what is actually happening, and have your mental checklist of all the things that can go wrong because of these treatments, and work backwards. So if they have swallowing dysfunction, you get a speech therapist to work with them. You work with a nutritionist to maximize the nutritional intake. You really carefully measure and monitor their muscle mass, and we have different ways of doing that. Evaluate their shoulder. Can they put on a shirt by themselves? What kind of exercise can you do to strengthen the muscles that are important for shoulder function? The swelling of the neck, there's, again, compression. There's manual therapy that you could do to address that. So I think there's a lot of things that you can offer someone that has had this history, and not even just recently, but years later. So that's the point I want to leave for your audience, is that you may have had head and neck cancer 5, 10, 20 years ago, and now you're seeing these effects on your function that you can't explain why. You go to multiple doctors, they can't figure out what's going on. The truth is that these late effects of the radiation therapy affecting the soft tissues and nerves and muscles under the skin where the tissue was irradiated, that are the reason.
And is it ever too late to come and see a cancer rehabilitation physician like you? Years later, I'm having this problem 10 years later?
Absolutely not.
Okay.
So ideally, like I said, we'd love to see them early
before
on.
you've already said
Right.
you want to see them before they even have their treatment, right?
But even in the later stages and years later, glad to see them, because the principles still apply. What's the impairment? What's the impact on quality of life? How do we work backwards to address them?
Right. And then you made a comment about the mental health issues and the suicide in head and neck cancer, and you really didn't stress that in some of the other cancers we talked about. Why is that in head and neck cancer? Is it more in the head and neck than maybe in breast cancer or gynecological cancer?
That's a great point. And I'm not a psycho-oncologist, but I can share with you that I think in all cancers across the board, you have to be very vigilant for the effects of cancer and cancer treatment on mental health. And there's a very high prevalence of mental health challenges in people who are facing and dealing with cancer across the board. I think in head and neck cancer, that's actually a little bit even more so, because of the significant impact that the treatment, and if you think about head and neck area, there's a lot of important structures there. So as a result, I think this population is at higher risk for developing mental health problems according to scientific literature, but does not necessarily exclude
Everybody
all
else,
other cancers.
right? Yeah, so everybody could have that risk. Obviously, so we've learned quite a bit today about this rehabilitation in cancer patients. Obviously, a new topic to me and a new topic to our audience. I think some of the take-home messages that I want to reiterate was, get an evaluation and get some type of, you maybe even begin your treatment plan even before you begin your cancer therapy, right? And then obviously continue along with your rehabilitation physician, and it's never too late.
Absolutely true. Absolutely true.
All right. And then obviously, what about, some of the great things that we've been able to do at Miami Cancer Institute? Obviously, you've been there for some time. Maybe can you share with us some of the great, examples of how you've helped some of those patients with the program that you have there that are obviously cancer survivors, thank God. And, some people think that that's the best part of it is you're a cancer survivor, which is very important. But obviously now you've improved their quality of life.
Fortunately, I've been truly blessed by working at MCI. I think it's a wonderful environment. The practitioners are top notch. My colleagues, they're from all over the best institutions in the United States. They've been brought here, and I've been very fortunate in that. I think there's one or two examples of patients that stand in my mind that will particularly resonate with your audience. So as you know, in cancer patient and cancer care, clinical trials are very important. What's the latest clinical trial that you can have someone that can enroll in that and benefit from that treatment to improve the quality of life and the longevity of life? And I had one patient actually a few years ago who was a very frail person sent to us for a shoulder problem. And she actually was someone that came in for that particular problem. But again, we approached it, what's the impairments and so forth, and we addressed her balance issues as well as her shoulder problem, her strength, general strength. And then I would see her in the community, and now she was walking with a cane, and she's going to events. And then I ran into her oncologist a few months, maybe a year later, and he said, "Oh, by the way, remember that patient that came to your area? Well, you know what? Most surprising thing, her physical function improved, and then she qualified for a clinical trial because her level of function was now at the level that she could participate. So she got the benefits of this clinical trial." Because her level of physical function had improved so much. So that stuck with me a lot because it tells me that cancer rehabilitation has tremendous power and impact on not just quality of life, but even longevity of life. And there's literature out there that even says that exercise is part of cancer medicine. There's a whole body of literature that just focuses on that. And I think that having rehabilitative interventions early, carried through, and actually surveillance of these patients for functional deficits throughout the cancer journey into survivorship, I think that is a take-home message.
Wow, that's an incredible example because I'm thinking about, well, you maybe saw her at a party and she was dancing or something like that, but no, you've allowed her to become so functional that she can get additional treatment and qualify for, state-of-the-art, maybe research projects. So that's incredible. Well, thank you. Thank you for coming today. And obviously for our audience, to remind you that being a cancer survivor is important, and that's very, very important, but your quality of life after your cancer is as important. And so obviously at Baptist Health and Miami Cancer Institute, they have a rehabilitative program, a cancer rehabilitative program with Dr. Adrian Cristian, and obviously will help you become obviously very fruitful and very happy and reach your goals after your cancer survivorship. So Adrian, thank you for coming.
It's my pleasure.
Thank you for all the information. Thank you for educating our community. And once again, Dr. Anthony Gonzalez from Miami Community Health, welcoming you again and reminding you to be healthy and take care